Well, greetings, P2s, and this is Dr. Rick Hess with Pharmacy Practice, and I am attempting to try this Tegrity recording for the pre-lab and for Ideals 3. My goal is to keep this recording short, to about 15 minutes or so, to keep it simple, to kind of give you a prelude to what you'll be doing in the lab. And as the title suggests, we'll be performing a medication reconciliation, and each of you will get to do this individually. This sounds rather simple and straightforward, but yet it's such an important and foundational skill that we want to make sure that everyone gets an opportunity to practice it. I make all my APPE students perform this when they meet with patients, and so it's amazing how even though we assume that we can do this and we assume that we can do it well, knowing it and doing it are actually two different things. So it is a skill, much like from communications class, as you recall. Interviewing patients is a skill as well. Let's see if I can move this down a little bit. There we go. All right. So our learning objectives, of course, listed right here. I'm not going to read those verbatim for you, but basically that's what our objectives are for today, listening to this particular Tegrity recording. And then again, as I said, you will actually see, you'll actually get to perform the medication reconciliation next week in lab. So what exactly is medication reconciliation? Some people call this brown bag, where it's basically where you're getting together with a patient. Optimally, that interaction will occur face to face, though in medication reconciliation can also occur over the phone. But here's a definition for you, and this is defined by the Joint Commission, which, if you recall, Joint Commission is the organization that accredits healthcare organizations. And so in their eyes, here's their definition. And so you're comparing medicines that a patient's taking or should be taking with newly ordered medicines and resolving any discrepancies that may take place. So obviously our goal here is patient safety. If you want to boil it down to just a couple of words, our goal is patient safety. We know that medication reconciliation, when it's done effectively, can reduce errors, and it can also reduce patient harm. And where this occurs, if you look at the second goal in the bottom, it says to ensure safe and effective medication usage across the continuum of care. This is something that's going to be ongoing. You know, it's not a one-time thing. It's not just a check box per se, where you say, okay, I've reconciled the medicines, I don't have to do that ever again. What we're going to see in transitions of care, like for example, excuse me, when a patient leaves a hospital with new medicines, or even when, like for example, they're going into a nursing home, or they're leaving a nursing home, or any transition of care from a acute setting to a chronic setting, or vice versa, medication reconciliation activities should be ongoing. So again, the idea is to make sure that the people are taking their medicines correctly, and this is a patient safety issue. We've been shown to reduce patient harm when you perform it correctly. So it is important, excuse me, the Joint Commission National Patient Safety Goal has been set for it. Reduce ADEs, adverse drug events. And when they looked at the data, they actually found that about half of the hospital-related medication errors and almost a quarter, it's up 20%, but almost a quarter of adverse drug reactions are really due to poor communication that transitions of care. So this is an important time where patient medication reconciliation can actually improve outcomes. And these errors are costly. The Institute of Medicine, of course, here says that medication errors is the most common type, contributing to thousands of deaths each year. And the costs associated with that can translate into the billions, with a B, the billions of dollars. So The medication history, who does it? Optimally, we believe pharmacists are the best trained professionals. When it comes to knowing medicines, pharmacists are the best. When it comes to the training that you are receiving with medications, you are the ideal healthcare provider and professional to perform this service. However, in a lot of incidences in healthcare organizations, in clinics and hospitals, it's done by other providers, other healthcare providers. It could be nurses or physicians, but in the research that's been done, oftentimes these other professionals don't do the job as well. Pharmacists document more admission medication changes than physicians do. Where as pharmacists, we're kind of tuned into the details, and we realize that when you're talking about medications, there's lots of intricacies associated with them and how people are taking them. And documentation is really, really important. In fact, in Archives of Internal Medicine, which is a medical journal, a few years ago performed a systematic review, and they specifically say that interventions that use pharmacy staff and focus on patients at high risk for adverse events, that pharmacy as part of that interprofessional team is vital for medication reconciliation. Now, as pharmacists, if we're not able to do the actual MedRec, then you can provide leadership in developing the best practices on how people should be doing this, or even training others, other like nurses or physicians, or people training others who are doing or actively involved in this process, how to train them to do it and do it best. So it's not silo, it's interprofessional. You're going to be not only doing this, but working with other individuals who are also involved in patient care. So the evidence, as I said, pharmacists do this the best, and that's basically what this slide is summarizing. Pharmacists are more likely to record and document the medications appropriately, allergy information, dosages, frequencies, tracking down discrepancies as well. And this is important. This is our follow-up plan, essentially, sometimes, where you've talked with a patient and you got questions and the patient can't answer it and you're unsure if they're using a medicine correctly or not. Who do you go and talk to? Who do you communicate that with? How do you resolve those discrepancies? How do you track them down and find answers to the questions that maybe the patient or the patient's caregiver, in some cases, couldn't provide? And just to summarize, pharmacists obtain medication reconciliation forms are more complete, and you need that documentation. So what is the list going to include? Well, a good medication reconciliation is not just a list of drugs. And this is what a lot of my students sometimes do early in their APPEs. If a patient comes into the clinic and provides them their wallet card of their medicines, for example, they just assume that that wallet card is up to date, which sometimes it is, sometimes it's not. It assumes that patients, just because a drug is on the list, that they're taking it correctly. And by correctly, maybe they're taking it at the right time, or maybe the technique is off. I mean, think about somebody who's using insulin incorrectly, giving it at the wrong time, or maybe not even injecting it correctly. That's not going to help them very much. But if it's on a piece of paper and it says that they're giving their insulin 2-3 times a day, then it looks good on paper. So here's what we're really looking for. Are all the doses documented? And not just prescription doses, but asking about herbals and supplements. Oftentimes, the OTC herbals and supplements are not listed at all on a patient's medication list. We find that a lot in clinic. Are there any inappropriate medicines? Are there duplications, any interactions, expired medicines? Like nitroglycerin, for example. If somebody has that on their list, ask the question, when was the last time you got that refilled? Because it's a medicine hopefully they're not using very much, and if they're not using it much, they may not be thinking about getting it refilled, and they may not know that the potency of that drug expires or diminishes over time. And so, are they using any inappropriate medicines? Are they getting them filled even at the right times? That's an important follow-up question. Here's another one, PRN meds. Are they using them appropriately and correctly? So if you got an inhaler on, albuterol inhaler on a patient's medicine list, how often are they using it? If it says 1 or 2 puffs Q46 PRN, are they using it every 4 hours, every day? Or are they using it just once or twice a week? Those are important follow-up questions that you need to know. Are all the medication allergies listed appropriate? Are they really true allergies? A lot of times people will have intolerances listed in their medication allergy list, so documenting that. Do they have an immunization record card? Probably not. I mean, most of the time patients don't carry around their immunization history. And then finally, a good one, a good medication history is also going to include what pharmacy do they use. So if you had to get information about refill history, if you had to find out who's prescribing this medicine, and a patient can't tell you and you don't have access to that kind of information, you need to know who you can go to find out. And pharmacy or pharmacies sometimes, knowing their contact information and where they're getting their prescriptions is an important piece to solve discrepancies. So performing it, this is what you'll all be doing in this lab. Explain the purpose of why you're doing what you're doing. I have to do this often in clinic, where explain to the patient, why are we going through your medicines one by one in such detail? Especially maybe perhaps if they just saw their primary care physician less than a month or so ago. But don't assume anything. Just explain to them the purpose. This is to make sure, this is what I say. I want to sit down with you and go through your medicine list to make sure that what we have is complete and accurate and it's documented. And really this is just to make sure that you don't, decreases the risk of you having any bad adverse effects from your medicines. And when you explain that to patients, like I just did, it takes less than 30 seconds. They're perfectly fine with it. They're not going to say, "Oh, no, don't talk to me about my medicines. I know exactly what I'm doing." When you frame it in the sense of this is for patient care and for patient safety, people don't mind doing it. You can ask if they brought a medicine list. That is helpful, though you don't want to just assume that just because they have the list that everything's accurate and correct from it, but it is helpful. And if they don't have their medicines or the list or prescription bottles, then be sure to ask good open-ended questions. And in D2L, there is a open-ended question technique, like a hint list, a cheat sheet, something to help you with phrasing some of these questions. And this is kind of bringing you back to communications course, and now it's kind of doing it in a light where we're looking at pharmacy-specific type scenarios. So you can compare the medicine list with physician orders if they're new, like if you're in a hospital, or with the previous history, which is generally what I'm doing in the AmCare clinic. I'm looking at what has been previously ordered and just making sure that what was ordered is what the patient is actually taking and receiving. And then finally, resolving discrepancies. And this is sometimes it's going to involve you teaching the patient, how to inject correctly, or how to use their inhaler correctly, or when to take a medicine on schedule instead of PRN, or vice versa. So that discrepancy could involve patient teaching. It could involve following up with a prescriber or the pharmacy. So with your current medicines, with the patient's current medicines, we want to at least document this. We want to know what the medicine's name is, and we don't want to ideally say pink pill or blue pill. We'd like to know and document what the actual dosage is, if patients know it. If they're taking vitamin D over the counter, they may not know exactly how many units they're taking, but ideally that's where the discrepancy would have to come into play. Have the patient to call you, or you call the patient when they get home with the actual dosage of some of the medicines, over-the-counter medicines, if they don't know what the dose is. The dosing schedule and duration of therapy, and then of course reasons for taking the medicine. This is important that people know and that we document this. Now when you think about doing a med, it's not just really about what they're currently on, but it's very helpful to also know what past medicines they were taking and how long they took it. What was the outcome? Why did it stop? And at clinic in our EMR, we can see discontinued medicines for patients. And one of the things that can be embarrassing for my students is that if they look at a patient's medicine list and they say, well, why isn't this patient on a statin? They need to be on simvastatin. And they're ready to make that recommendation. Well, they haven't even bothered to look whether or not the patient was ever even on it previously. And maybe you're doing some follow-up as to why it was stopped. And if you see simvastatin on their discontinued list, along with maybe a few other statins, then you can probably come to the conclusion that they have tried it, maybe they didn't tolerate it, and so it kind of helps prevent embarrassment when you're given recommendations to a prescriber on a particular regimen that a patient maybe could benefit from, when in actuality they've already actually tried that. So knowing what kind of medicines they've been on in the past is helpful. Now, not everybody that you see is going to be an accurate historian. Not everybody that you see that you need to perform a medication reconciliation will have the competency or the skill set to, or the knowledge about their medicines to provide this. So when you're dealing with children and you're dealing with geriatrics in particular, you need to be a little cognizant of this. Is there an adult or a guardian that can provide information if you're talking about dealing with young children? And I don't deal a lot with children in my practice, but I do deal a lot with older adults who, for whatever reason, don't give or don't have the capacity of giving good, detailed medication histories. They don't know their medicines, what they're for, or even how often they're taking them often. And that's very frustrating and dangerous too. So, sometimes you got to kind of go the extra mile to make and ensure that what patients are taking, that they're actually receiving. And so with geriatrics, often what we may have to do in clinic is to follow up with a caregiver, maybe a daughter or a son or a spouse, or identifying who is the primary person who's responsible for the safe medication use of a patient who you believe is at risk. And then finally, we got to document it. And you'll get a chance to practice this in lab too. There's no one form that is standard. There's no one form that is ideal. And we've provided on D2L a form that you will be using when you meet with your standardized patient to go over their medicines. And as the old people say, if you don't document it, it didn't happen. And this medication record, this medication reconciliation needs to be part of the medical record and needs to be communicated to other healthcare providers, or at least put in a format that they can easily access and review on their own. And then, of course, following up, what's not on this slide, but following up with any discrepancies. All right, so that's kind of our prelude. And then just real quickly here, as we look at the syllabus, week 11, this is where we'll be at. Each of you individually will be interviewing an SP, and we'll be forming a med rec. And I wanted you to look also at the rubric that's on D2L. And that's the rubric that we'll be using to evaluate you and provide some feedback. This is also on D2L. I mentioned the medication reconciliation tips, using open-ended questions. This is something you can kind of look through at your leisure to kind of prep you at asking good open-ended questions, which is one of the things that we will be looking for. All right. I understand that you all each have a schedule, and this is the individual communication skills interview times. So we will be following this schedule format for your individual interviews. Well, I think that's probably about up. I don't know if it's been 15 minutes or not, but that was my goal. If you have any questions after listening to this short recording to prep you for the skills lab that we'll be doing in IDEALS 3, please shoot me an email. That's probably the easiest way to reach me, and I'll be sure to follow up with you. I hope you have enjoyed this recording, and if I can figure out how to stop it, we'll be over.